To our second speaker, our colleague, Dr. Faisal Salim. He has a fellowship of Royal College of Physicians in Edinburgh and Oman Medical Specialist Board program in 2010. He is certified board in internal medicine, and he worked in adult nephrology at King Fahd Hospital, National Guard, Medical City in Riyadh. He is a very active colleague, and he is going to speak today about common medical complications of transplantation, Omani experience. Please.
It's bird kidney donation.
Sorry. He's going to speak about bird donation. Thank you. Thank you for coming.
Assalamu alaikum. Good afternoon, everyone. Thank you, Chairperson. Thank you for giving me this great opportunity to present today in this esteemed conference that had holding a lot of interesting topics, including my own topic, which is the principles of paired kidney transplantation. I'm going to try and give an overview about this interesting, not easy topic. I have nothing to disclose. The outline of my presentation is composed of an introduction, why transplant is the ultimate treatment option, what is kidney paired donation, KPD, and why it is a solution. What is some of the world experience in KPD, types of KPD limitations and challenges, allocation system that is designed in different type centers for a KPD, and a conclusion. Now, kidney transplantation is, of course, as everyone knows, is actually the ultimate form of the best treatment of renal replacement therapy. And this was alluded much during the past lectures. The number of kidney, however, transplants, of course, is not enough. There is a big organ shortage worldwide. Disease donor organ program is one of the solutions, and the ways being designed to increase the pool, expand the criteria for donation, but is it enough? Living kidney transplant is still superior in comparison to the disease donor transplantation, and that is by far related to the graft survival. So for sure, we need to develop novel strategies to augment kidney transplantation rates through expanding the living donation pool. And this is just to allude fast, the survival of transplant in comparison to patients who are on dialysis, of course, superior to transplantation. However, that also alludes here that the waiting list for kidney transplantation in comparison even to the other organs is very high. And 1/4 of those cases are actually transplanted. It's not enough. So another reason for a novel strategy needed for living kidney transplantation is the ABO group. So unfortunately, ABO group incompatibility or even pre-existing donor human leukocyte antigen and DSA are major barriers to live for the live donor kidney transplantation. It actually renders exclusion up to even 54% of otherwise really inappropriate pairs. So when you look at the living kidney donor options, either it's for compatible recipient donor pairs, desensitization program for highly sensitized patients, ABO incompatibility programs, and what I'm advertising, kidney paired donation program, also known as paired exchange. So what is it and why KPD? It was first proposed in 1986, but not until 1991 that the first KPD transplantation was performed in South Korea and gaining, of course, an international recognition. KPD is an option in which the donor kidneys are exchanged with another prospective donor recipient pair who also biologically incompatible. Yeah, meaning it enables kidney transplant candidates with willing but incompatible living donors to join the registry of other incompatible pairs in order to find a potentially compatible and better opportunity. So the KPD programs have become really common in the last 2 decades and may represent one of the most really a good opportunity to improve transplant rates. Worldwide, Australia, Canada, South Korea, and United States, and many other European countries have developed this robust paired kidney program involving 2 or even more pairs. Depending on priorities and policies and depending on the program, the countries itself, and acceptance of such programs, it evolves differently among different countries. Whether it's a single center KPD transplant program, which is done, for example, in Romania, Turkey, and India, or a multi-centered type with national registries, like, for example, in Netherlands, UK, Canada, or Australia, or even the USA model, whereby it's a multi-center or even hospital-based KPD program, most notably, for example, the National Kidney Registry or the Alliance of the Paired Donation, or even the Johns Hopkins Hospital Incompatible Kidney Transplant Program, and so forth. In GCC, in UAE, I think they have established a good program in the kidney paired program, and it is even recently they had a 3 pairs transplant exchange. Now, in terms of the volume of the kidney paired donation programs in Europe, whatever the way and the means, it's going on very well. For example, in Canada and in Australia, around 45% of those patients that enter the registry have gotten this transplantation using this method. And this is just another figure that shows that the number of recipients transplanted in blue and newly registered are doing very well in Europe in different countries. Now, let's talk about the types of kidney paired donation. There are different types, and it's a sort of a mathematical scheme, but I'll try and make it as simple as possible. So you got here what is called the KPD using the closed loop, conventional. And whatever the potential is a limitation, I will allude to that later on. So it's simply an exchange of donors between 2 pairs in a different type of way. So donor A will donate to patient B. Donor B donates to patient A, and this is what is called 2-loop. You can increase to 3-loop or 4-loop according to that, but it's a closed conventional. It's a challenging type. Why? Because the transplants must be done simultaneously. It's performed to guarantee that all recipients should receive a transplant and eliminating any risk of a withdrawal or withdrawal of the consent of a donor. And also, of course, that will leave an orphaned recipient. So it's a resource intensive. It requires multiple operation theaters and multiple surgeons. It's challenging, especially if you have limited pool of pairs. The other type is what it is called non-directed anonymous donors, NDAD, and non-directed anonymous donor chain. This is simply also known as Good Samaritan or altruistic donors. They can initiate many more transplants without obligatory matching of a paired recipient. It guarantees a minimum of 2 transplants via what they call domino chains. Such chains initiated by an NDAD and terminated with the last paired registered donor, and of course that or waiting a bridge donor to initiate a future non-directed anonymous donor. And similarly, in USA, they adopted this in some centers, and they call it the never-ending NDAD chains, whereby the terminal donor waits a bridge donor, initiating a new chain at a later date. What are the challenges of such NDAD and that is enrolled into the KPD? Is that some ethical concerns that have been postulated by some of the authorities. The version of all NDAD into the KPD program further possibly diminishes opportunity of highly sensitized patients, recipients on disease donor waiting list. So there is question of an equity concern. A potential solution for that actually is the requirement of a policy whereby all NDAD are first allocated within a defined group of the highly sensitized transplants waiting list recipients. If no suitable recipient is identified, the allocation to the KPD program proceeds. This is the example which is done according to in UK. However, the issue of that is a simultaneous arrangement of this long chain is really logistically challenging. The chain may be performed non-spontaneously despite the small risk of donor withdrawal, chain breakdown, and orphan donors. Some programs actually mandate that the recipients of any registered pair must be transplanted before their donor to reduce the risk of the orphan recipients. Other programs allow a donor to donate first before the recipient is transplanted to reduce the risk of donor withdrawal if relevant. So it's a bilateral thought. The other type is what's so-called the unbalanced KPD. It's used to increase the KPD pair numbers in inclusion of ABO HLA compatible pairs who may also benefit from receiving a transplant better suited for them, giving better chance, better graft survival, better matching. So this altruistically unbalanced actually first proposed mainly as a solution for the blood group recipients in the KPD program. So one APO incompatible pair may be matched with another compatible pair, but non-identical pair, optimizing, of course, the number of living donor transplants. So donor blood O gives to patient blood O, donor blood A gives to patient group A, in an unbalanced called two-way that can be expanded to three-way as well, and so forth. It's challenging. The compatible pairs in KPD may be disadvantages by waiting for a match. You have a delaying in transplant that may otherwise have proceeded because of waiting for this matching and better opportunity, of course. It is generally felt that the altruism of their participation should be balanced by the benefit potential. So you balance that accordingly. An unbalanced KPD can be attractive for otherwise compatible pairs who have high degree of HLA mismatch. And of course, if you have a good allocation algorithm that provides a better HLA match for the recipient and the compatible pairs. So in terms of the allocation system in KPD, centers may create the system that suits their situation and the program. So whether it's a single versus multi-center, the matching algorithm for selection of donors and recipients pair within the KPD pool is a keystone for any KPD program. So you have to optimize in order to maximize the potential number of suitable matched donor to recipient pairs in any cycle. The ranking factors are there. These ranking factors considers the blood group matching, the likelihood to the recipients, suitable DSA or cross-match negative donor in the pool, number of HLA mismatches, the donor center to recipient distance, the donor to donor or donor recipient age difference, CMV status and ABV status, time of the dialysis. So however, whatever the means, mind that regarding the above, a timely living donor transplantation is of paramount importance. The virtual cross-match is helpful in approach to allocate the suitable donors and the registered transplant candidates. So the extent of HLA antigens included the virtual cross-match varies among different registries. But donors are usually typed a minimum of HLA A, B, C, and DRDQ. And in some registries, they include the DQA, DPA, DPP, and DRB3, 4, and 5, depending on the center itself. So what are the limitations of KPD? There are several. As I stated earlier, there are some ethical limitations, concerns, actually, I might say, but often not possible to match all pairs depending on the size of the pool. And that's a problem. And you know, the patients who are blood group O recipients are at disadvantage because they accumulate in the list because they are the universal donors, the blood group, the universal donors. Similarly, in comparison, the AB donors are accumulating in the list. The donor themselves are also actually now are at a greater pressure. There is no excuse now, according to this, that incompatibility is removed. So they have to donate. So this is also, by some, considered that as pressure. Ethically, there is an issue with that. This is just a small comparison, comparing the advantages and the disadvantages of single versus multi-center kidney pair donation transplant. So if you look into that, if there is a single center, the donor pool is less in comparison to the multi-center. The donor transport not required in comparison to the multi-center type of KPD programs. The shipping of the kidney is not required in the single center in comparison to the multi-center. The surgical team skill is universally in comparison to, in a single center, in comparison or controlled in comparison to the multi-center, might be different. Even the requirement-wise, the cold ischemia time is less in the single center in comparison to the multi-center. Hospital atmosphere you have to consider, and as well the follow-up may be the same center in comparison to different centers to follow. And never forget the cost. So the single center is less costly in comparison to the multi-center. So the way ahead actually to this difficult topic, actually I might say, is that good physical and psychological evaluation is actually needed for a decent kidney pair donation program. And developing this matching software, immunological testing, organized framework, and central coordination is essential. Of course, the support of the local country clinical leadership to establish a confidence in KPD as one of the treatment of choices for immunologically complex recipients, incompatible recipient donors, pairs that seeking actually better age or better matching. Also, you have to ensure that the recipients and donors are appropriately informed about the treatment options. The centralized follow-up system, developing it is very important to monitor the effectiveness and the quality control of the program in terms of the impact on the donor recipient and more generally in terms of the overall outcome. It is important to encourage innovation and continuous improvement. An effective kidney paired program might increase the volume of kidney transplant actually through predictive models by 2 to 10%. And of course, the public awareness for the presence of this, this program is of crucial element for good support as well. Thank you very much.
Thank you, Faisal, for this excellent talk. By the way, just to mention that in Saudi Arabia, we have